having me here today. My name's Kate, as you've been told, and I'm a registered nurse. I'm the programme manager for Frailty at Imperial, which basically means that I look after any older adults in the first kind of 48 hours of crisis, so whenever anything changes in their situation. I'm an advanced practitioner as well, and I come from an emergency department background, so that's just a little bit about me. Obviously, I'm coming to you from London at the moment, so my apologies if anything that I say doesn't make any sense to you guys, but I'm sure you'll be able to ask me afterwards. And so Chris has already given you a little bit of an overview of the trust, and I just kind of wanted to give you a bit more detail. So we saw just over 1.1 million patients last year across all of our 5 sites. We have only 2 emergency departments across those 5 sites, and they saw about 300,000 patients. And some of you will be aware that in London there's an awful lot of hospitals per population. So although we cover quite a significant population and we have quite a significant number of hospitals, none of our hospitals are extremely huge. So we have a total of 1,160 beds, and we cover patients from essentially 8 London boroughs, although we are at what we call a tertiary centre. So we deal with some of our really specialist patients, for example, within vascular, that could come to us from anywhere in the UK. And my service covers 26 care homes, which is 1,307 residents that we look after within the service. So just a little bit of background about how the service came about. And when I talk about remote monitoring, I like to talk about it in the context of the whole of the service that we offer, because it's a really, really valuable tool in our arsenal, but it doesn't really make sense on its own. And I'm sure all of you guys will understand that. So there's often been a barrier between care homes and health services, particularly acute trusts. And some of that is driven by the fact that, as I assume you all know, that the National Health Service is obviously nationally funded and is a public organisation, but actually our care homes and our residential homes and nursing homes are all delivered by private providers. We started off just looking after one care home in our borough because they're quite big. They have 147 residents. They've got very complicated patients coming from really complex backgrounds. And they actually were accounting for 50% of all admissions into one of our sites within the trust. They had a working relationship with a geriatrician from the trust, so we thought it was a great opportunity to bring some additional nursing care and some more advanced nursing into it. We then have expanded the programme a couple more times, and we'll talk about that in a bit. So the 2 main interventions are really focused on boots on the ground, essentially. We've got 2 liaison matrons. The role of them is to kind of bridge the boundary between our acute trust and the care home system as well, making sure that we provide continuity of care across the whole system. So one of the really complicated things in London is that all the different bits of care are delivered by different providers. So our acute trusts cover obviously their acute care. We have community trusts that cover the community care, and they're all run and operated separately. And then we're all managed directly under what we call an integrated care system, which links up all the providers together and kind of has oversight but doesn't deliver any services. It can be a bit different in other parts of the UK, but London's very complicated for this. Because as I said, we already cover 8 boroughs, so that's 8 versions of every single thing we've spoken about. And so trying to navigate care across that whole system can be quite a challenge. So the matrons do a lot of proactive care planning, making sure that we're prepared for patients' end of life wishes or advanced care planning. They do lots of reactive stuff. So often we find that people get conveyed to hospital for things like catheters blocked, and absolutely they don't need to come out of their own homes for us to deal with that. And so the focus is admission avoidance and reducing length of stay. There's a big piece of work around education as well, and that's making sure that we, as the biggest provider in the system, share all the resource and knowledge that we have outside of that as well. And so I just wanted to share with you some results that we had before anything changed. And so you can see in this that with just one care home in not quite a year, we managed to save just over 1,000 bed days, which is the equivalent of closing 3 beds. Now, I understand that 3 beds in the whole system doesn't sound like a whole lot, but in trusts which are always historically challenged for beds, every single bed day counts. And as you go through, we added some additional homes in. And so the second home was a nursing home. And when we headed in 3 and 4, although we only had a couple of months to test that system, we actually started adding in residential homes. And then, if you see the next slide, COVID hit. And COVID-19 really struck us, probably really started to ramp up at the beginning of March. We went into national lockdown around the 23rd of March, and that's when our case numbers were really starting to rise. At the time, we were still very much talking about, travel history and not mass community testing. And so our community services didn't really realise they were seeing the effect of it until quite near the end of March. Obviously, we recognised that there was a need for more. We'd done some work in our local homes. We realised that we had COVID running in our homes. And the reason it was a little bit slower for us to realise is because we didn't have any testing for our community services. We didn't have any testing in our care homes at all. And those patients didn't display your kind of classic COVID symptoms. And patients were the biggest predictor that we found, and we did a bit of research around this, but the biggest predictor of COVID-19 within our care homes was actually anorexia. So not the fever, not the cough. We noticed that patients were rapidly deteriorating, and we also noticed some anxiety within our providers and starting to send in a lot of patients to our hospitals. So for the very beginning of April, we ramped it up from 4 homes to 26 homes and decided we could see what we could do. So we changed the priorities of our matrons a bit. We had to rapidly make some advanced care planning decisions and have some very difficult conversations in a very challenging time and environment where you can't see patients, you can't see relatives face to face, and they can't be with their relatives in the homes. We had to gather a lot of information and make sure that we were sharing that appropriately. And obviously, information sharing laws are really challenging, but equally, we needed to make sure we were doing the best things by our patients. And that obviously reduced our proactive work a bit, and we had a lot more focus on an IPC. And we explored some new ways of working. And we were lucky enough to be offered some current health devices that had been previously deployed to the trust to use for elective surgery, but obviously we stopped doing any elective surgery to focus only on pandemic care. So this is the current health device that we used. It gives us all the same information as the one that we've been talking about, but this is kind of the first device, the first version of the current health device. As you can see, it's a little bit bigger, and they've released the second device earlier this year, which is the one that you guys have already been shown. Even though it's a little bit bigger, you'll see that we didn't have any trouble with compliance either. And bearing in mind that a significant proportion of the residents that we look after have quite severe dementia, and even they weren't really bothered by it. Once we put it on, got it under some clothes, they didn't fiddle with it really at all. So we commenced remote monitoring at the beginning of May, and we rolled out really quickly into 11 of our homes. We picked the homes really carefully, because we had only 2 matrons on the ground covering 26 homes, and we had some people who weren't able to work face-to-face clinically because they were shielding, and so we're at home. We had some people helping us out on the phones and where at all possible, but very limited availability of video calling as well. So it was another thing we were really excited about with the remote monitoring. So we picked homes, the homes for us that the nursing homes that were the ones that we were struggling to get into, or that had particular challenges around COVID. We picked some residential homes because they don't have the availability of nursing support, and so sometimes we found it particularly challenging to when we spoke to them to get a real clear picture of how their patients were doing, and the same with the extra care sheltered. We've got 22 monitors in use at that time, and we've been monitoring since the 4th of May. So these are some of the results, and you've already seen that 87% of the residents that we monitored ended up not being admitted to the ED, which for us is a really important system win, I guess. Overall, we would monitor, the average length of stay for a care home resident is about 6 to 7 days, well, was about 6 to 7 days. And so we managed to decrease that to about 4 days on remote monitoring. So that saved some overall time in care. And as you can see from here, 92% of our patients were perfectly happy wearing the device. And like I say, it was bigger than the one you're seeing, so that's great. I wanted to talk to you a little about some of the interventions that we were able to deliver as a result of the remote monitoring. So a lot about advice to the team on how to manage those residents that were either high risk because of their comorbidities or high risk because of their anxieties of being brought into the emergency department. And we were able to monitor and revise quite a lot of medication, particularly around things like postural hypertension, and also some kind of fluid overloads for our heart failure patients. Making sure that the care plans that we'd set up were delivering was a really good way of us being able to keep patients in their own home and referring on to other services as well. And the kind of last bit, we talk about adding medical equipment to the care plan, and interesting that Adam spoke to us about they'd recognised a patient with sleep apnea, because that's actually happened for us as well. So we don't monitor our patients overnight because we're not big enough team to manage it, but we do monitor our patients from 8 in the height of the pandemic till midnight. And what we found, that we had one gentleman who was regularly falling asleep during the day, which is probably not that unusual, and that we were able to add some additional equipment to manage his sleep apnea, which we'd noticed during the day. But kind of, to put this into context for you, we're looking after 26 homes on 2 matrons, and the estimated cost in those first 3 months of savings would have paid for a whole nother matron for a whole year in the UK. So that's what 62.5K means to us as a system. And so I just wanted to talk to you a little bit about some of the things that we've learned, and you'll have this copy of this presentation recorded anyway, but so some of the really positive stuff for us was that we had eyes on the patient without going in and having physical contact, and it's far less invasive for the patient than coming into our hospitals. And also, because of the COVID pandemic, patients don't want to be in hospital and they don't want to be there, but it saved some time for us. We could video call. So in the UK, a lot of care homes don't have any kind of connected devices, that most of them don't even have Wi-Fi. So that ability for us to deliver and care virtually and actually see those patients and really understand what was going on for them in a really visual way was really valuable for us. There were some things, kind of balancing measures, I guess you would call them, in that we did have some heightened anxiety in some of our staff, particularly in those care settings where they don't provide 24-hour care. Because they weren't used to seeing some of the observations and the numbers, and they're not necessarily capable of interpreting them. And we did do quite a lot of work around interpreting trends, and that we found that the measures were most useful when we were looking at it from a trends point of view rather than looking at it as a snapshot. We sometimes struggle to get our general practitioners engaged with the system as well, which meant that, when they wanted to change medications, we ended up doing the monitoring for them. But, you have to give everybody time, and everyone was obviously very, very busy. And obviously, it's really important to remember that observations are only as useful as the whole clinical picture, and we would very much advocate, don't treat the numbers, treat the patient. And things to go forward for us is about making sure that staff really understand why they want to use the monitor, what they want to get out of having the access to such high level, really, really great data set in terms of, ITU level monitoring. But this is, patient's own home. So we need to be really clear why we want to have that information and why it's relevant and why it's going to help us. And some of the data that we collected from our experiences wasn't as quantifiable as just being able to say, well, we saved this much money, because actually if our patient experience was really, really good, and our relative experience was really, really good, and our care home experience was really good, and all of which they were, that's much harder to kind of demonstrate the value in a UK system where it's not quite so driven by finances. And so just obviously some of the terms in here won't be familiar to you, but I just think it's really important to mention that we really needed to be sure that we were working really well with all our community partners, because you can't keep patients out of hospital, even if you've got the best set of vital monitoring, if you cannot engage your community partners to support their care delivery in the right place. And so we talk a bit about early escalations. Some of the things we did was we made sure that we had meetings across the system. So obviously I've explained that our system is a bit more complicated than just being one trust and one community service. So we made sure that we have daily meetings at 12 o'clock across the whole system, that we have really robust governance structures, who maintains the clinical responsibility. And in this case, it is always the GP that maintains it. But it really helped us to make sure that we improved our pathways and we improved our communication with everybody that was involved. And just the last slide for you from me is some overall results for our services. So you can see in here that we saved some attendances, quite a lot of attendances, and we saved some re-attendances where patients have come back within 72 hours. Obviously, we saved admissions. Length of stay you'll see on here, so that's the total number of days that anybody was in hospital. It has gone up, and we expected this to go up. And the reason for that is you're stopping all the patients that don't need to come in or end up coming in for 24 hours because sourcing out their care is really difficult. We've stopped a lot of those, and therefore the patients that come in really do need to be there, and that's why the length of stay has gone up a little bit. But overall, you can see the numbers, and I appreciate these numbers are in pounds, and just to convert for you, the overall change is equivalent to about $2 million in less than a year's worth of work, 9 months. And that number is probably underestimated because we based it on King's Fund, which is a national standard of how much it costs to have a patient in a bed. But all of you will understand that having older adults in your beds can sometimes end up being more expensive because they have an increased care level. And so I hope that all made sense to you, and I hope that our experience working with older people and the challenges that they have reassure you that Current is still an excellent tool in the arsenal of the things we can do to look after people. So I'm just going to hand over to Amy, and again, thank you for having me.